I'm going to introduce the panel first, and then Nola will do the acknowledgement to country. So we have Ian Gentle, who is the Senior Development and Cultural Security Officer at Department of Health. Kerry Colgate is Aboriginal Engagement and Cultural Advisor at St John of God. David Corbett is coming, and he's the Aboriginal Health Liaison Officer here at Royal Perth. And Nola Naylor is Director of Aboriginal Health Strategy at South Metro Area Health Service. So thank you, Nola.
So good morning, everybody. I'd like to acknowledge our elders past and present. I acknowledge the land in which we stand, Noongar country. I would like to acknowledge the Aboriginal people in the room, my colleagues and confidants and friends, and the Aboriginal people that happen to be linking in via teleconferencing, and the non-Aboriginal people in the room. And I hope today's session is a very sound opportunity for you to build on your skills and knowledge around cultural business through taking care. So good morning, everybody.
Yep, thank you. And I would just like to confirm Nola's acknowledgement by acknowledging the strength and resilience shown by Aboriginal people throughout the colonisation and extreme government legislation that forced dispossession of their land, suppression of their language, and dislocation of their families. I can have no clue how that would feel. So I'd just like to acknowledge that and welcome you all here with an open heart and an open mind as we learn from the Aboriginal people within the room. And I'd just like to start. Communication is a huge part of us all being human beings and connecting. So, Nola, could I ask you, vulnerability and fear may be emotions felt by Aboriginal people on entering a hospital. With this in mind, many of the questions that came through were about respectfully building rapport. Could you speak to that, Nola? Thank you.
Certainly. So what we've found with a number of our Aboriginal patients is when they come into the hospital, they come not just from Metro, they come from regional remote. They haven't sometimes experienced being in the city. They've never experienced coming via a plane or coming across country for service provision. And so there's a number of things in relation to just experiencing something new, and the cultural factors in relation to language and other components along those lines. They're off country, and that's another huge concern for them. So they're coming on to another Aboriginal person's country, and what actually happens in that space is also a concern for them. They're isolated, they're disengaged from their family, and they don't have support networks around them. So there's a number of key things in that space.
Yeah. Kerry, would you like to add to that?
I guess just, Nola probably touched on most of it, but I think it's just ensuring that, you're aware of, or asking the question of ensuring that you know where they come from. Obviously, foremost, importantly, is contacting your local or your ALO that's within the hospital to support you in that process. Importantly, through that whole engagement, it's about sort of providing that cross-cultural education from the ALO to the clinicians to ensure that you're informing them constantly on effective engagement and appropriate engagement also. So that's really critical too.
Yeah. Ian, would you like to add to that? How we truly find out what matters to you, what matters to each person?
Yeah, hi guys. I think one of the key things we need to understand is the fact that whenever we take someone out of their home environment and put them in the fresh new environment, which is where they have no self-power or self-determination within their own culture, the fact happens then is they're actually in a cultural shock environment. So we need to make sure that when they do come down, or people do come into hospital, even people from Metro go into hospital here, they come into a foreign environment. We need to make sure that foreign environment is structured so that they understand that there is a routine, but also the fact that they need to understand, we need to make our staff understand that they make them feel comfortable. Make a connection to the individual by a place, a land, a sport or something else, just to bring them out of their shell, to have a yarn and make them feel comfortable. Then only once they're comfortable in the health system, within the hospital, then they're actually able to take steps to actually looking at how they can get better without stressing. And also when they come in, it's about also making sure that their family and friends actually know where they are and visit and stuff like that as well. And making that an easy process, not a struggle when Aboriginal people come to visit.
Yes, and I believe, that we've spoken prior to this, and, maybe talking about the footy, maybe talking about family members, babies, young family members, talking about community, talking about the land, talking about the food. Just find that connection is so important, that Aboriginal people listen so well. Unlike me, they don't need to fill the silence. They're very respectful in that way, and I certainly have learned a lot from that, and very reflective too. So it's about engaging as you would with anyone. Yeah. And Nola, about communication, are there words or things that we should avoid?
So just what a number of things that we as Aboriginal people do is when we walk in, we don't just say, oh, hi, I'm, Mr. Blogs or whatever. We walk in and, we say, how you going? And, can you tell me a bit about yourself? And so initially when we first engage with them is a completely different thing from just, who are you and what are you here for? Or, I'm not suggesting that that's what you do, but so we come from a completely different background. And then we start to build a bit of a picture about, who they are and how they're connected and where they're coming from in their country, family and things like that. So there's some of the things. And there's specific words that and I think we're all familiar with what those words are. We wouldn't refer to something even in language unless we're feeling confident that we have a rapport with somebody. So we wouldn't specifically refer to them as blackfellas unless we have an affiliation. So I think that it is really important that unless you have some common ground with the individual or with the country or and people, then you wouldn't use those types of things. And as I said, remembering now, you wouldn't use racist words or anything like that. So you would be very conscious around those elements. Anyone else want to comment? Anyone from?
Yep. Yeah. Sorry, 2 mics.
They went wine glasses. I think from our experiences at Midland, what we try and ensure is that each time that we are called to a patient, I always kind of prioritise that the clinicians are there talking with us. So it's always that ongoing learning continuously. We don't always want to be seen as the solution to Aboriginal issues all of the time across the hospital. We all have the responsibility in treating and caring for Aboriginal patients. We don't want to see we as the problem, because it's not like that at all. So I think importantly, that ongoing effective engagement and that ongoing continuous learning is absolutely critical for everybody when working in this space. So, so that's the approach that we continuously use. We're always involved together, we plan together, we communicate together, and that then leads to effective discharge planning.
Yes, that's true. It's a team effort. Yep. Oh, Ian.
Yeah, hello again. One of the key things I find, and like the ladies are saying here, is make a connection with the individual. I look in the room and I see a group of Aboriginal people here. Most of them, I have a connection with them and I know who they are, where they come from, because we ask a question. We ask a question, hey, where's your mob? Who are you from? And we do that. We'd make that connection first before we actually do any other business. Once we do that, then we actually talk about how can we work together, what are you here for, who's your family? And to do that for us is actually how we connect as Aboriginal people. You might have heard that, and you might have heard that a lot of times, but it's also if you can't connect through family networks, you connect through country, you connect through, you live up in Mount Newman or somewhere like that there, in Newman. Okay, well, I've been up here, I've been there, I've been there, I've been a jig-along with all those places, and they make a connection. And then you might know an individual from that community that you worked with in the past. Providing they haven't passed away or something like that, you can actually use it. Well, I remember such and such, I used to work with him or do that with her. And, you know, things like that are actually, you'll see the eyes light up and you'll see that connection. And that's what we are all about. We're all about connection, and it's all about how we feel ourselves. Because if we don't feel good and feel comfortable within the hospital setting, then we're not going to be susceptible to actually assisting the health service, our own health. It's going to take a longer time for you to, you're not comfortable. And the wording, the names, the language you use, what Nola talked about, is about knowing or experiencing where they come from in the first place. And, you know, the things you can do that by is actually get your hands on a couple of the maps, which have the language, the areas in the maps, knowing the communities where they come from. So if someone came in from, let's say, One Arm Point or somewhere like that, if I was on the wards or somewhere, I'd look at One Arm Point and I'd look at some of the areas around there and have a yarn about that to that individual to make that connection. Because once you make that connection, then you're there, particularly with our mob.
Really open for Aboriginal people in the room if they want to add something that we haven't felt that we've covered. So please feel free to do that. I really appreciate your input and expertise in that space as well.
We'll make that connection.
Yeah.
So my question relates to something you said earlier around when Aboriginal people come in from remote communities and they're coming off country into another country. How can you actually make them more welcome? So the reason for the question is that I'm project managing 3 residential step-up, step-down facilities for the Mental Health Commission. So we're building one in Broome where I know that we're going to have a lot of people coming in from remote areas within the Kimberley. So what can we do, what can the NGO do to actually make those people feel more comfortable when they come into Broome?
Yep.
I suppose initially, one of the first things is having an environment that's conducive for our mob. Understanding, as Ian says, the need. Like Kerry said, it's just whether or not you've got an ALO or finding somebody who's critical in that point for the patient. They're really quite key things. So understanding the patient in the first instance, understanding who, why they're there, and what's important to them, and the priorities for that individual are also a priority. Because if they have business outside of their time in as a patient, then their mind's not there, and that already makes them more anxious. So there's some key cultural competency components that you can look at even before the patient comes in. Does that help? Is that?
It's more about that coming off country and into another person's country. So that's very much where I'm...
Jess Linwood.
Yep.
Thank you.
Having relationships and rapport with other community organisations such as CAMS and Brahms and others, but also tapping into networks that are working closer with the local community. And like, if you're in touch with the Aboriginal medical services in the region, then there would always be somebody there that can actually support you and guide you. There's also the Kimberley Interpretive Service, so if they don't speak English or don't have English as their first language, which is quite common in that area, then you've got the Kimberley Interpretive Service to actually help you, guide you and interpret for those people that come in, because language is a real big barrier. And I guess for yourself, when you're communicating with Aboriginal people, it's how you present yourself first initially, because it only takes 3 seconds to read you like a book. Yes. In our eyes.
Yes.
So it's really important to actually conduct yourself in a manner that you want people to be receptive of you.
Yes.
Yeah, that's cool, Lynn. Thanks for that. A long time no see. How you going? Also to that, in my experiences of working in rural communities in South Australia and Northern Territory, is a large area from a major resource capital like Broome, for example. All of those areas around there, whether it be the Kimberley or the Pilbara, well, the Pilbara will come down a bit further, but the Kimberley, for example, a lot of those are all connected through family and relationships and culture and other things. So what we as Aboriginal people see as a community is not infrastructure. what we see is space and relationships and country. So you might get people coming from all over the Kimberley coming to that place, but that place, people's already been there. People already know people from there through a first cousin, sister's, nephew's, uncle's kid, or whatever it might be. And through culture or through whatever other way they do it, they will actually have a connection. So what you need to do is look, what we need to do as a health service is look at how we can assist them in making that connection when they get in there, knowing where they come from and knowing if the system of the family system actually allows them to do certain things within the people you have in there. Because sometimes someone might come to your service and they might not be able to talk to somebody else in that service, or they might feel comfortable in talking to that person in that service based on who they are and how they're related to people. But just remember, when you're working in an area that big, it's the understanding, the conceptualization of community is space, not place.
Yep.
Yeah.
Yep.
Kerry, would you like? Sorry. Okay, thanks then.
Yeah, just going on from what Ian's saying, it's also important, I guess, in that space to understand the culture of the people in the region, because in that region the kinship systems are totally different, and so it's understanding so that you don't put their families, but I know one of the real cultural issues there is that mother-in-laws and sons cannot talk, so it's being aware of the culture that is within that area as well. And you can only learn that, I guess, by communicating with the Aboriginal people and being receptive and they be accepting of you to actually share that level of information with you.
I think importantly from an urban setting, it's more of a challenge, I think, because we're a lot more diverse within the city limits. So when you're more or less working in those discrete communities, I think you've got a lot more access to those resources. So it's about you obviously exploring and making those general inquiries. I think also what's really important and what we don't do so well is right up at that first initial stage at the ED area, the questions that we ask, we do ask of the Aboriginal identification, but we could probably go a little bit more in depth and start asking about, where are they from, where are people from, just so we can help better plan. So in saying that, then we need to obviously supply or, provide those resources in those settings to support that a lot more, stronger for that to make that work. So I think that, at that stage, it's really, really important because it just helps us get off from a good foot from the start.
Yeah, and we will touch at the end. One of the next subjects is all about culture. So we'll take the question that came from which VC
We're
side?
not sure which side.
Okay.
The question was, is that still appropriate for a non-Aboriginal person to also build rapport by asking about where you're from and place of country?
Look, if we as Aboriginal people know that someone loves our country and they've visited our country and they've been there and they've loved it and they love the people and they've visited the people and stuff like that, and they've made a connection with someone from that community, if that individual names someone from that community they met, oh, that's my uncle. And that connection is instant. And then they start having a good yarn and it's connective. And so the more we as healthcare professionals look at linking our experiences to the land where these people come from, the better, because then we can actually identify who they are, where they come from, and they can see that they're interested in us.
Yeah.
And that's one of the key things. It doesn't matter where you go, that happens really, really well. I was talking to a guy the other day in a shop, and he came from a place I've been to in northern Queensland. And I knew several people, and he said, "You're joking, that's my first cousin sister's kid." And that connection is actually just makes things so much more worthwhile. No matter where you go, make a connection. If it's not a place, if it's not a person, it's a place or a building or a river or something like that. And people say, and that's the best thing. That's one of the good things you can do. Because two things are important to us: interpersonal relationships between our groups and land and where we come from.
Yeah.
We might move now to what health is to Aboriginal people. So hospitals can symbolise a place of death and dying rather than healing. Nola, would you be happy to speak
Sure.
to that from an Aboriginal
So
perspective?
I think health means a lot of things to a lot of Aboriginal people. Holistically, we see health across a number of things, as just in relations to the communication this morning, our connectedness to one another, our connectedness to the land, the animals, the water and that type of thing is very spiritual to us. So holistically, health is quite encompassant. So when we talk within the clinical context, it might not necessarily be the priority. So once again, Kerry's said it on a couple of occasions in responses to communication. It's really understanding the patient and the priority of the patient. So you can get a patient who might be critical ill, and then who will feel that that's not necessarily the priority of what's going on at home might be. So it can mean many things for many different reasons to the individual. And once again, it's really important how you engage, and Lynn emphasised on that. You've got a certain amount of time to actually engage, and we pick up on body language very quickly. And depending on how we receive you, in whether you're walking in the room or your ambience, when you're sitting in the room with us that we enter into, there's just so many different things that have an impact on that. So we might have a burning question in relation to that. We might actually, want to ask a question and we might not. And so when we're asked a question, we might even just say yes, because it's easier just to respond with, well, yeah, okay, rather than actually exchanging information that's critical to us. So there's a number of different things that you need to do to lead up to that. And the only person that can actually qualify what's important to them in their health is the individual. And if it's not the individual, then, as Ian has said earlier, identifying somebody with that, whether or not the individual doesn't come up with it, but whether it's an ALO or other people in that space that can actually assist you in getting to better understand the needs of that one person. But widely, for Aboriginal people, health is critical to us, because we do need to keep ourselves well for our families. We've got huge responsibilities. We're not like Wadjulas, like white people, in the sense that we have a very generic family. Our responsibilities are very wide, and so that impacts on our capacity to and our needs and what we see as important to us as well. So you want to use them up?
I guess when I think of this question, there's so much that goes through my mind, but there's a lot of our people that will access hospitals rather than their GP. So there's that, and then there's this, that they see it as a place of dying rather than healing. So it's really a sort of a tricky sort of little area, but I believe that in some of our experiences is that what I notice a lot is the communication. It goes back to that communication again, and that updating of their treatment and care as such. So it's just ensuring that you're going back and continuously talking to them and letting them know what's happening, what's the hold up or whatever the case is going on, because I know a lot of our mob get very anxious sitting there and not being spoken to, so they're very unaware of really what's going on with their own health and what, with their own treatment as such. So therefore that leads to, the Dharma stuff, so the discharging against medical advice. So, then obviously then it starts all over again, that cycle. So I think if I can only encourage people, our clinicians, to ensure that they're, continuously updating our people when they're in hospital, involving them in decision making around their treatment, and not just seeing it from the biomedical model, but also ensuring that you're capturing the cultural needs of that person and what that looks like when they get home as well, because it'll again, the dynamics change. So it is about bringing the two together and making it work, and it is possible. So that's really important. You don't want to talk?
Yeah, taking on from Nola and Kerry was saying, one of the key things we have with Aboriginal families is our obligation to other people within our families, our family groups. And one of the key things happening nowadays is a lot of our grandparents looking after grandkids, because there's been an issue with the system within the family. So it's like when they first brought in the closing the gap in relation to the cheaper medications, the fact that if we were to go and buy medications at the going rate, and we had the option to buy medication or the option to feed our grandchildren at home, we would feed the grandchildren at home and go without the medication. We would do that. So what happens is we will put the responsibility and the obligation of our family in front of our own health. And that even happens sometimes. I won't go to hospital because I've got to look after these kids. I don't have the hospital because I've got to look after my husband. I've got to go to the hospital because I've got to look after my wife. And those are the sorts of things that happen within our family. So what the system's ideal scenario would be to look at how we can support those systems those family systems outside the hospital. Or how can we help our community go to a GP early, see a GP and understand the issues of their health before they get to an emergency stage where they go to A&E. Because that's what happens in a long time. Under the closing the gap in relation to the care coordination process, that's what happened with that. The role of that was to go out and to talk to the GPs and the practice staff, particularly the receptionists, on how they should deal with Aboriginal people when they come to your service. Because one of the key things that happens is they ask a whole lot of questions out in the open and they shame out our mob, and our mob gets so shamed that they just walk out. Or you haven't brought your Medicare card in again. Nice and loud, so they really use the word pissed off at our Aboriginal people. So Aboriginal people just walk out. I've seen that happen. I've done that. And I'm pretty savvy with the health system. But I'm ill. I don't give two rats about what they think about me. And as soon as they say something that upsets me, I'll go somewhere else. And then I'll wait until I'm very, very ill, then I'll go to A&E. But yeah, the system in relation to obligation to other family members is first and foremost within our groups. So we need to make sure that how can we support that happening is by getting our mob to better understand and be health literate before they get to that stage of emergency, to actually go and seek help and manage that. That's why the co-payment measures in with Close the Gap and stuff like that. So we need to all understand how that works and how we can get access to that as well.
So one of the things that we've tried to do to lead up to this session is to enable you to be as informed as possible, to participate and upskill you around your knowledge and awareness around Aboriginal people. And one of the things that's quite key in this area is that our past history in relation to the impacts of policy and acts on Aboriginal people. So our removal from the land, as we had identified, are very critical to us. Our being disengaged from family, and then and the types of impacts that it has on us personally and within our families, and who our standing, our cultural understandings of who we are as Aboriginal people, our practices, and the many other things that actually happen in that space because of the history. And the history is ever living today. So I'm not going to expand too much on that, but I think that they're the key things that you need to be building your capacity and understanding around to better enable you to actually assist the Aboriginal patient. So when they come to us, as Kerry has identified, they come to us with many other things, into whether it's emergency or they're admitted for a procedure. It's not just the clinical care, it's about many other things that they're accountable to and for. So their personal health is a priority. But the way we live and the way we lived is very different, and it's a very contemporary world now. And even for the most functional Aboriginal people, with having comorbidities from diabetes and other things, it makes it very difficult to just get up some days and function in a very white world. And we live in two worlds every day. So they're the things that it's really quite, I put back onto you to get better understanding around, because I think it's quite important for you to be more aware. And happy to assist, at any stage. I think any one of us would be willing to offer up our knowledge and awareness at any time.
And that was going to be my next question, was what does a good health system look like to an Aboriginal person? Obviously it has to start by including family, including community, including respect, including trust, good communication. But just some thoughts on what a really good health system looks like to an Aboriginal person.
Oh, this is a really big question because my belief is that the system does not advantage those marginalised groups. So again, Aboriginal health is such a big issue for everybody, has a huge portfolio across the whole country. So, what aren't we doing right? We've been talking about these same issues for the last however many years. And again, we're still talking about system change. So I don't know who is responsible for that in those areas and those spaces, but until, those systems do start changing and start benefiting those marginalised groups, then we'll obviously start seeing a lot of difference. But, otherwise it's just status quo. We're constantly always having to advocate. We're constantly having to always, include and embed those processes in. But again, it's not seen as core business. It's always seen as an add-on or an after effect. So it's really critical that, those senior people at those higher levels, we need those people to start sort of advocating a lot more stronger. And lobbying, further to government and places like that, because at the end of the day, we need to ask ourselves the questions, are we serious about closing the gap? Are we serious about change? Otherwise, let's just forget talking about this all the time, because nothing, for me, it remains status quo and we continue to talk about the same stuff. So, yeah.
Yep.
I think, from my perspective, as I've been, I don't know whether it's lucky enough or unlucky enough to actually, within the last 12 months, spend a lot of time in tertiary hospitals. And I think some of the things that I find more easier for me as an individual, and I've lived in a whole range of places, but I don't have the same experiences in my life with other people, and I can't speak for everybody, but I speak for myself. And I think is having, one thing, we do look at how the hospital manages our people, and we need to manage that really, really well in relation to knowing where they're from, who they are, and how people relate, and the cultural shock we get when we come to hospital. Because when we do come to the hospital, we're actually in a very stressed state. We've got to understand, we come into a very, very stressed state. So therefore, one, we're just removed from home, we're just being removed from our family, we're just removed from our eating routines, our sleeping routines, and everything else. If we did that to somebody and moved them out of the community, the opposite, in reverse, in a mirror image, how many would cope? They would cope, but they would cope in a space of time. So we've got to make sure that we understand that what will happen when an Aboriginal person comes into this system. Even for me, it was very difficult. But one thing that helped me is that my literacy around health and my health needs. If we can get that right somewhere in the community in health promotion or primary health care before we get to the tertiary system, and the expectation of the Aboriginal people when we come to our hospitals, and the expectation of the hospitals and how we treat Aboriginal people, we meet that line together. I think then we might be able to have better outcomes for our people when they come to hospital and when they go home. But when they go home, we've got to be able to link those services to people so we don't come back. We've just put them out the door. Or they don't, what's that word you use? When they go off?
Dharma.
Dharma, that's it. Yeah, Dharma. I'll get that one, boss. How that works, we need to make sure that we can actually track the whole patient journey and make sure that we can do it properly. But also, preempt. Closing the gap was to minimise the gap. But to minimise the gap, we've got to start back here. There's all different age groups. So we need to make sure that within the services that we have out in the communities and within the services we have within the tertiary hospitals, there has to be a linkage. We can't be doing this in isolation. So if we're doing it in isolation, it's just moving people from stockyard to stockyard. And that doesn't work.
So I think that we're actually, moving on that journey that it allows us to provide better care and service provision to Aboriginal people. And I know that there's a number of those non-Aboriginal people sitting in the room, and I can, think how fantastic they are about how they communicate with our mob. I think that one of the things that's critical for you to understand, and Kerry pinpointed once again, is open communication and keeping the patient engaged. And informing them about where they're at if they're in the health setting with us, because that will dissipate their anxiety, and it will keep them informed. And then, and it's quite repetitive even with the family. You might need to not only say that with the patient, but you need to say that with the patient's family as well. So there's some key things around that. And what we see is we have a very hierarchical cultural processes within our own practices, and they actually like the budia, the doctors. They're really important to them in that space, and they want to hear from the doctor as to what it is. So even informing, like our doctors are getting more appropriately in relaying information, and Christine can probably, who's very fortunate to be here, about how they deliver information to the patient around their care and what's actually happening for them physically. So there's some key things in relations to that. And keeping that person engaged, I suppose, is the most important thing.
Can we take Christine? Would you like to add to that?
For those who don't know me, I'm Dr. Christine Clint, so I'm the Director of Aboriginal Health Services out at St John of God, which is kind of a hallmark appointment, really. So I'm liking the thought and the idea, like what Kerry's, I'm echoing it, in terms of let's stop talking about it, let's do something about it. So while I find this a really challenging role, I know that it's really important too. And it's about having our mob at the top level sometimes to be able to push the Aboriginal agenda. Okay, I'm just going to be straight up and honest about it. But in terms of clinicians being able to talk the talk now and getting the health messages across, which is pretty much what most of us here are, concerned about. I like to think that my other job that I have, which is an academic over at UWA, so I actually teach this. So this is kind of bread and butter for me. So I'm really proud of you guys up there, echoing that, and I'm like, yes, I'm putting out the right messages too. In terms of that, the communication, I really couldn't have said it any better than you guys. And Kerry and I have this conversation pretty much weekly, and like our messages are not any different. What we said 10 years ago, 20, 30, 40 years ago, some more than that if we're that age group, and I'm not giving you my age. But just be aware too that some of us are living legacies still of those policies and acts, and we bring that with us as well. And unfortunately, if you don't understand where we're coming from in the first place, it's going to make your job very, very difficult. Am I asking you to say that we should give special privileges to Aboriginal people? No, not at all. I'm going to challenge this, and I've been putting this out pretty much this year, is it really an Aboriginal health problem, or is it an Australian problem? And that's the way we need to look at it, okay? But we need to have that cultural lens, but we need to take responsibility for the health of the Indigenous people of this country. It's an Australian problem, not an Aboriginal problem.
Thank you, Christine. Thanks very much. Cheers. Thank you. We might... Any other... yes, up the back.
Hi, I'm Karina Moore. I'm from Health Networks over at the Health Department, and something that's been troubling me for some time, and it cuts across working in the subacute space as well as communication. There's this increasing push, particularly for rural and remote areas, to have telehealth services, and they are for more acute things than we're traditionally using them for, as well as in the primary care space. And I'm just wondering, what are the red flags around that for Aboriginal people?
Would you like to talk to telehealth and... Right. Oh, Lynn? Lynn's happy to answer. Yep, cool. Thank you, Lynn. Lynn Dimers from the Heart Foundation.
Just hold it right up.
Yep.
Thanks, perfect. Thanks.
For engaging, I guess, with telehealth, How do you build a relationship and a rapport with the people if you've got them on a screen? People don't like to be sitting in front of a screen. They don't like sitting in front of a camera. There's no way it's going to work. Some people like it, and it's great for the health professionals in the region to actually assist the Aboriginal people, but you'll never get a relationship with Aboriginal people by talking to them through a monitor.
Could I ask one of the panel members to speak to that?
Just to add on to that, I know that in the telehealth space, from the Children's Hospital, particularly in the Aboriginal space, it's actually working quite well. So I think that there's a number of people that are doing a number of things behind the scenes that actually assist and aid the communication for individuals to be sitting in that environment, and they're key things that you need to consider. And having the appropriate people to support individuals to engage in that. And I know that it is a way forward. And I know that it's something that they are tabling on numerous occasions. And people are actually agreeing to it because they don't necessarily want to come off country. So I think there's opportunity. It's how you actually deliver that information and what are the pros and the cons in relations to engaging in that space. And I do, I don't disagree with Lynn. I think it's a difficult process, but it's one that I think, dependent on how you do the background to achieve the outcome, is the most important part.
Beth? Yes?
Yep, that's good. Yep.
Lovely. Great. Thank you, Beth.
Yes, I know. Thank you. I'm Beth, and I'm the Plastic Surgery Telehealth Coordinator. And I'm proud to say that as a service, we provide care for patients, often acute as well as post-acute, to more Aboriginal and Torres Strait Islanders than any service in Western Australia, and I reckon in Australia as well, but don't tell anybody. Do you know the key thing to telehealth is not what I do at Royal Perth. Oh, I always get emotional. It's being a team.
Yeah, that's right.
It's the nurse sitting in Derby or in Bidgidanga who sees the need for appropriate, timely, specialist care and says, I will help you from Royal Perth because this patient needs that to go on with their living. We are a team, people, and we need to work as a team. And I really don't think it cares about the colour of your skin. Sorry about that. I think that regardless of who you are, respect and culture and the importance of communication is essential. And all I can say is go telehealth. We are doing fabulous things for people living in remote and rural sites everywhere across this beautiful country. And we need to keep moving forward with that because the care needs to be, as the panel have said, timely, appropriate for the patient needs.
Yep. And involving family, involving health professionals, which
God, you'll never get me off the microphone.
Oh, yeah, come on, go back.
But isn't that the thing? You see someone in Bidgidanga, and much to my horror, the whole community comes with them. The raucous noise that comes at video conference.
Great.
You have the health professional there who can say, hey, Beth, what you're suggesting might be great in Perth, but it's an absolute shocking idea here. Let's try something different.
Yep.
You have community involvement. People don't need to leave country to get the best care they can. It's fantastic.
Thank you,
And just
Beth.
on that
for your
note,
passion.
Kerry emphasised that a little earlier, just in relations to if people want to leave, there's other opportunities through telehealth to actually link people in. So it's being creative in that space and knowing what's available to you. It's a way forward. Absolutely.
Jessie, yes, definitely. Yes, Lynn, please.
Do you two want to sit together?
I have to totally agree. If it's integrated
Yes.
care and you've removed the silos, then sure, it's going to work. But in a lot of instances, there's still so many silos up there and nothing works in a silo. So your explanation of telehealth, where the team have already got the rapport in the community, you've hit it on the head, and they do bring the family with them, and that's really important. But if you want to deliver solely to the people themselves, it's not going to work because it's still in a siloed effect. So I totally agree with everything that you've just said.
One question that came through to us, which is truly huge, is could you please speak to what a day in the life of an Aboriginal person living in a remote community looks like? Who would like to? I'll always default to Nola where I have to.
Anyone in the room want to respond to that? Thomas,
Yes, someone
come on,
from
Thomas.
Yes.
I knew there'd be somebody in the room.
Good. Yes. No, it's not.
Is it working? Yeah. But basically, when you go to the community, it's about unity, it's about smiling, it's about being free. Right? No one judges you. Everyone's there to support you. You don't get that in the city. See, someone who may not even like you will still ask you if you want help. In the city, it won't happen. You know what I mean? And that's the basis of the unity of a community. It's more powerful, more beautiful, more loving. You know, wherever you go. See, that's the one thing about it, because others are put first, not me, I, like in the city. Big difference. But we can all still work together to work out a way to get it going.
Thank you. That was beautifully spoken.
Thank you.